afternoon, everyone, and welcome to the 18th installment of the UP PhilHealth webinar series, Stop COVID Deaths, wherein we talk about the clinical management updates on COVID-19 cases. And for our season 2, we have been having the format of virtual grand rounds, but specifically for today's episode po, we will have a very special episode in that we will be holding the very first National Virtual Town Hall Meeting. And as always, I'm Dr. Raymond Francis Sarmiento from the National Telehealth Center of the UP Manila National Institutes of Health. And with me, as always, also is my partner in crime and my mentor and a dear friend, the Special Envoy of the President for Global Health Initiatives, Dr. Susie Pineda Mercado. Dr. Susie.
Hi, Raymond. Kamusta? Good afternoon, everyone. I'm looking at the list and we've got again, everyone from all over the country, Zamboanga, from Iloilo, kamusta po kayong lahat? We hope you'll enjoy today's webinar. We have very special guests and we're going to talk about very important topic, helping our health workers stay safe. Raymond, it's 200 days since the start of the pandemic. Ang bilis ng panahon.
Really, it really has been, wow, it's nearly half a year already, no po?
Yeah.
For us to be able to experience all of this. And as mentioned po by Dr. Susie, the theme for today's virtual town hall meeting will be keeping our healthcare workers safe, but specifically focusing on the PGH experience. But not only on the PGH experience, because we will have reactors from the directors of other hospitals po. Who will be joining us in the panel. And we have a very special guest po who will be delivering our opening remarks. Dr. Susie.
Sige, Raymond, tell them first about the certificate and then we'll go straight to our special guest speaker.
Thank you so much, Dr. Susie. Before I go into the details po, no, with regards to the certificate, I just really would like to thank everybody and everyone who has been helping out and making this learning series possible. The team is comprised by different colleagues, mentors, and different really hardworking individuals from the University of the Philippine system, from the Philippine Health Insurance Corporation or PhilHealth, over at the ITDC or the IT and Development Center of UP System. We also have our production team over at TVUP, yung pong ating mga nanonood at sumusubaybay, lalo na po yung mga hindi po nakapasok sa ating Zoom webinar. Sila po ay nare-redirect sa YouTube channel ng TVUP. So maraming salamat po sa panonood pa rin po. We also have over at the UP Manila side, the Office of the Chancellor, the Office of the NIH Executive Director, at the Philippine General Hospital, the College of Medicine, and at the National Telehealth Center. And for the certificates po, as mentioned in our previous episodes, and this was in our previous season pa rin po, only those who have been able to stay, so kung nakalagin po kayo, ano po, sa ating Zoom webinar, but only those who have been able to stay for at least 50% of the duration for the webinar will be receiving a copy of their certificate and also a link to the presentation slides po. Well, we have been sending out certificates in the past few days, and hopefully lahat po ng mga eligible na makatanggap po ng certificates ay nakatanggap po ng certificates, except for those for webinar number 13 wherein we are still trying to edit po some parts of the slide presentation by our resource speaker. Dr. Susie.
Okay, so we have a national virtual town hall meeting for hospitals, and it wouldn't be national if it were not for having our national leader in health. So it's my honor and privilege to welcome to the webinar series our Secretary of Health, Dr. Francisco Duque. Secretary, welcome to the National Town Hall Meeting.
Yes, magandang umaga sa iyo. Maraming salamat sa iyong mabait na pagpapakilala, Dr. Susie Mercado. Iniwan po ako sa PhilHealth Board of Directors. Ayan tuloy, lalo ka pang bumata nung umalis ka.
Sir,
Pwede nga lang.
Sir,
Anyway,
Oh, so thank you for joining us. You know,
Of course.
I think people don't realize that when we had avian influenza, yung H1N1, you were cited by the World Health Organization as one of the three outstanding ministers of health for that outbreak. What's the difference between what happened then and what we're going through now? Anong reflection nyo dyan, Sec?
Ang laki difference, Doc Susie. Unang-una, yung AH1N1 pandemic, meron siyang Tamiflu o
Yeah.
Seltamivir na panlaban.
Right.
Dito, kakapa-kapa lahat. Ano? So, malaking diferensya, and during that time, we did not have to put together, wala pa tayong IATF noon.
Yeah.
At ito kasi talagang ang karanasan sa COVID-19, talagang matindi. Hindi mo masukat eh. Sa ngayon, it is a novel virus. It keeps evolving. You don't know which corner it's gonna turn. So, di ba? So, ang hirap talaga. And it has really brought the whole world to its knees. No? And we're part of that global community, and we've not been spared. No? And so, that's why meetings like this are so important, so that we can continue to regroup, to re-strategize what are the best options, what are the best practices, new knowledge, new information from all over, from the different parts of the world. And WHO has been a significant bridge between us and the other countries, where either we learn from their best practices or how not to do things.
Right.
Their bad practices, no?
Yeah.
So, oo. So, yan naman, ang ibang-iba talaga. Hindi, parang I cannot even begin to compare the H1N1 pandemic, but hopefully the outcome will be the same. Sana naman, I pray and I ask everyone to pray daily that this COVID-19 evolves ultimately into a common cold virus.
Right. Sec, I was gonna ask you about that kasi minsan nabanggit nyo sa akin that you were doing some special studies in immunology in the United States. What do you think of all these mutations? You think it's becoming what should I say, it's going to be in a friendlier form. It's going to be something that should not be lethal. What do you think?
Well, that's a possibility. It could, the influenza pandemic of 1918, di ba? Nawala na lang siya kabod. Our SARS CoV-1, SARS-CoV-1, nawala din siya. Ganon. So, hopefully, over time, as it transmits itself into the communities, they say it could be tamer.
Right.
Although the infectiousness has increased, no, because the strain has evolved from a D614 to a G614 strain, which now I think the transmission is much faster. But luckily, and hopefully, let's cross our fingers, it does not mutate into the severity of the SARS-CoV-1 or the MERS-CoV-1, because everything is possible with the virus. They're very notorious for their ability to mutate. Diba? So, yan ang problema natin ngayon. So, kailangan we cannot afford to let our guard down. We have to treat this really as a very serious threat to us as a people. And so, we ramp up in every aspect of our pandemic response, from the prevention and compliance with the minimum health standards of wearing masks, physical distancing, face shield, washing of the hands. I think all of you are already tired listening to these reminders, but sometimes, the reminders have to be repeated to be able to achieve a genuine change behavior. No? Kasi ang problema sa mga Pilipino, minsan pasaway tayo eh. Kailangan kulit-kulitin mo eh. And then of course, the next pillar, of course, is the detection. Ano? Early detection is the key. And we need to do aggressive contact tracing. And isolation now should take precedence over testing. because testing is unreliable to the extent that the results, you get the results after 3, 4, 5, 7 days, lalo na may mga backlogs on account of unforeseen circumstances like lab techs, med techs getting sick themselves. They need to be undergoing quarantine and therefore cause delays in the release of the results. And then of course, isolation, as I've said, we need to do the Ravi model where there's a paradigm shift. Dharavi is the biggest slum area of India with 1 million households, and they've been very successful in that they change approach by from the patient going to the facilities. Inaantay mo ba yung pasyente pupunta sa mga primary care facilities? Pagkos ngayon yung gobyerno nila, yun ang pumupunta talaga through active case finding, isolation, and tinitingnan nila kung sino yung may mga sintomas, and kaagaran ina-isolate. So tapos yun, ite-test mo. And then of course, kung ano man ang kanilang maging sintomas, kung magkaroon ng komplikasyon, kailangan maayos yung referral network to the higher level facilities. This is now covered under the One Hospital Command Center. Si Doc Gap is very familiar with that. Kanina nga lang, sabi ko, kailangan buuin din natin yung One TTMF Command Center, yung lower level facilities, yung network noon, yung community isolation quarantine facilities, and then the national mega temporary treatment, isolation and quarantine facilities. And then there has to be a nexus between that lower level network of interventions to the higher level, which is now going to be the One Hospital Command. And then eventually, of course, meron tayong tinatawag na reintegration strategy into communities that by then should have already adopted and adopted and ensure that the new normal is in place. And of course, when you say new normal, it's really about minimum health standards. So yun po ang atin ginagawa sa ngayon. Meron po tayo ang IATF, which is a 33-member agency task force. It's difficult, managing a task force with 33 bright guys, very smart people. You have to sometimes referee if there are conflicting views. Some people don't understand. It's just that I couldn't make public kasi our meetings, but how I wish we could be more public so that they will appreciate the work that every member agency puts into the resolutions, into the decisions, working on appeals, and by monthly de-escalation or escalation of community quarantine statuses. So it's really difficult, but we have to be together on this. This is a fight of everyone. This is not just the fight of the national government, nor of the local government. This is really the fight of every Filipino. And that's the governing principle that in terms of our response. So we need to synergize. We need to find areas of complementation rather than areas of differences, because this fight is a serious one. It's a World War C, as they say. So we have a lot to do. And insofar as the hospital operations are concerned, it's not just about COVID, by the way. I want to underscore that this is not just about COVID, taking care of COVID-19 patients, but also the non-COVID patients. Dahil kung pababayaan natin, we're too focused on the care of the COVID-19, then it might be unwise that unwittingly the non-COVID patients, baka doon naman lumaki ang ating mortalities, doon naman lumaki ang dumami ang mga morbidities, and we cannot afford that. But to me, finally, ang gusto ko lang din sabihin, this can also be some kind of parang blessings in disguise, serendipitous, kasi parang yung na-accelerate yung universal healthcare because of the COVID-19. It's a catalyst. Although COVID-19 did expose the fissures or the cracks the weakness of our Philippine health system, it has brought to fore the areas, the provisions of universal health care that need to be accelerated in terms of its implementation. So para sa akin, no regrets. Andyan na yan. Let's do our best. Let's broaden the context by which we are responding to the pandemic. And that context is the universal health care.
Oh, thank you very much, Sec. You know, you're in. All your lieutenants are listening here. We invited all the hospital sec, and we also have a lot of medical schools and students that are watching. So, batiin nyo lang sila. That was a great message, Sec. I think it gave us an overview of what's happening and what you're looking forward to. And maybe you have a short message lang, especially to our medical students, our deans of medical schools, and our hospital administrators who are watching right now.
Yeah, yes, thank you, Susie. Unang-una, ako po ay taus-puso nagpapasalamat sa ngalan ng Department of Health and the Interagency Task Force sa ating pong mga healthcare workers from the Philippine General Hospital na nagpupursige at nagpupunyagi para kumalinga at mangalaga sa ating mga mamamayan, mga pasyente na may COVID-19 at ganoon din doon sa mga pasyente na hindi naman COVID-19 ang mga sakit pero malubha din, na kinakailangan din ng ganoon pangangalaga. At ako ay nagpapasalamat din dahil sa inisyatibo ng PGH sa kanyang pag-iibayo ng mga makabuluhan at makahulugang pananaliksik na siya naman ang gagabay at tutulong sa atin pagtugon sa COVID-19 ng buong gobyerno. At yan ay talagang mga frontliners natin at meron po tayong mga nakalagay sa Bayanihan Act 2 na magpapakita o magsasalamin na ito pong importansyang ibinibigay natin sa mga healthcare workers ay talaga nangingibabaw. At hindi ko lang po nabasa pa yung detalye ng Bayanihan Act 2. Pero ang sa akin lang, there are no shortcuts to our recovery as a nation from this. And above all, I emphasize protection of the health of the Filipino people should be the priority. If we are to interrupt the transmission of the virus, we cannot cut corners. Science, I repeat, science must be the guiding hand that informs every citizen, more so our local leaders, our employers, and industry players. At wala namang kaduda-duda, there is plenty of room for us to still grow and progress, and we are here today to do just that, to listen to each other, to collaborate, grow together to strengthen our fight against COVID-19. And this is a prime opportunity for us to transform our health response, and we have poured through our action plans, re-strategizing. Kanina nga lang, sabi ko, nakipagpulong po ako sa mga kumakatawan ng Health Professionals Alliance Against COVID-19 at pinag-usapan paano ba ang recalibration, re-strategizing para mas maging pino at para mas malinaw ang plano. Because if the plan is not clear, then execution becomes lousy. So clear plans must lead to very good execution. Again, all of this with the end goal of ensuring the protection of every Filipino. So I call upon all of our medical students, our nursing students, all those constituting the health professionals, groups. We have to bond together. This is not going to be easy. This is going to be a long haul until there is a vaccine. We will see a lot of, as Tomas Pueyo aptly says, the hammer and the dance. We just have to do cha-cha, one step back, 2 steps forward, 2 steps back, 1 step forward. It's now going to be already integrated in the way we live our lives. But we as the leaders must be able to provide the direction and the plans how we can implement all of this to ensure successful response to COVID-19. I mean, the whole world cannot stop just because of COVID-19. We must march on. We must sabihin ko sana, we should soldier on. Hindi naman soldier. We must march
Dance on na lang. Tech dance on na lang. Mukhang nagcha-cha yata kayo.
Yeah. Oh, so yun lang. Maraming salamat. Hindi ko na
Thank you.
binasa yung aking speech kasi gusto ko mas tayo informal.
Yes, of course.
Sana po ako ay makatulong. Bukas po ang amin na pinto. At kung meron po kaming maibibigay na tulong. Sa PGH po, patuloy kami nagbibigay ng healthcare professionals augmentation. Alam po ni Director Gapian na pagka isang tawag lang niya, nanginginig pa si Secretary Duque para lang tumutulong sa kanyang mga pangangailangan. And why not? You know, all his efforts are worth whatever assistance we ought to give PGH and all the other DOH retained hospitals. And in fact, we're expanding it to also provide augmentation of human resource for health to even the private sector. No? So, yun nga lang, ang mahirap po dito ako nangailangan ng tulong ninyo. Nananawagan po ako sa ating mga nurses. Alam niyo ba, parang may 1,000 yata na mga OFWs na bumalik, na mga healthcare workers na ang OWA, and I forget someone who tried to facilitate yung kung pwede silang bumalik bilang mga healthcare workers sa mga ospital natin. 25 lang naman na nag-sign up. Okay. Yung iba ayaw. So ako po'y nananawagan. I appeal to the sense of nationalism, the sense of patriotism of every healthcare worker. Asa gera po tayo, magkaisa po tayo, magtulungan po tayo dahil sa bandang huli, sino po ang kakalinga, sino po ang mangangalaga o gagamot sa atin pong mga kapwa Pilipino kung hindi tayo din mismo. So, baguhin po natin yung ating pag-iisip sa gitna po ng pandemyang ito at siguro let's be selfless. Mahirap po ito, hindi po madali ito. It's not going to be easy anytime soon. It's going to be more difficult, but we just have to live with it. But of course, the sense of nation must be an overarching consideration in the hearts of every health care worker, in every doctor, in every nurse, in every medtech, So kailangan po ito. Salamat po everyone sa inyo pong pag-anyaya at sana po ako ay nakapagbigay ng makapuluhan mensahe at kami po ay handang makinig kung paano po namin mapapaigi pa ang mga plano at ang atin pong mga isinasagawang mga pagtugon sa COVID-19 pandemic. Magandang araw po.
Thank you very much, Secretary Duque. A grateful nation appreciates your hard work, your perseverance, and all the things that you've been through. And without your leadership, where would we be? No? So we thank you for joining us today. So maraming salamat po, Sec. I know you have a tight schedule. If you're able to stay, we'd love for you to stay. But if you need to go, we just thank you for the time you've given us. Maraming salamat po. So Raymond, over to you. We have a welcome from the University of the Philippines in Manila. Let's introduce our welcome remark speaker, Raymond.
Yes, thank you so much, Dr. Susie, and thank you also for that enlightening message, Health Secretary Francisco Duque po. Maraming salamat po for taking the time out from your hectic schedule to join us in this national virtual town hall meeting. At on behalf po of the healthcare workers, maraming salamat din po sa pakikinig. Ang very first step po kasi talaga is to open the lines of communication, lalo na po dun sa nabanggit niyo po kanina, nakausap niyo po yung Health Professions Alliance Against COVID-19 na grupo. So maraming salamat po and hopefully we'll have a more strengthened plan in terms of specifically in terms of protecting our healthcare workers po. As mentioned by Dr. Susie, if you are available, Secretary Duque, we'd love for you to join our panel discussion. But at this point, we'll go on po to the welcome remarks by our dear Chancellor over the University of the Philippines, Manila, Chancellor Carmencita Padilla.
Okay, maraming salamat po Dr. Sarmiento at sa lahat po na bumubuo ng inyo pong town hall meeting. And Dr. Gap Legaspi, Dr. Susie Pineda, and everyone, thank you very much. I'll try to come back as soon as I finish my next meeting. Salamat.
Thank you, sir.
Thank you, Sec. Thank you po. Uh, okay, I think, may we call on the Chancellor, Chancellor Padilla?
Okay, so magandang tanghali po sa inyong lahat. I'd like to welcome you to our National Town Hall, a very unique and creative edition again of the virtual Grand Rounds. And I understand that we have thousands already in this webinar. And I just wanted to say a few things in my welcome remarks, because what we've learned is that from the lessons of PGH, we can actually pick up lessons for also the academic institutions. So under UP Manila are 9 academic colleges, as well as PGH and the National Institutes of Health. So first, what we're picking up now, so we're going back now to the schools, is that we're picking up lessons also from PGH on how they made the wards and the hospitals safe, but how we can make it safe now for our students. The second thing is, in this webinar, in this town hall meeting, we will understand that if we are part of either nursing or medicine or midwifery or dentistry, we cannot just actually talk about the COVID patients, but also the non-COVID. But let me tell you that there's one thing as the head of the institution that actually captured my conclusion about everything that's happened in the past 5 months. Just 2 words. In the past 5 months, I have seen the creativity of the constituents, PGH, NIH, and all the academic colleges, and how they can move on with their mandate as either teachers or hospital workers. And the second thing is that we have shown that we as a community, we as the Filipino community actually are resilient. So I do welcome all our participants from all over the country, from Batanes to Jolo. This is for you, and let us learn from each other. Magandang umaga po sa inyong lahat.
Thank you,
Thank you so
Chancellor.
much.
Yeah, thank you, Chancellor Menchit, for that, again, very inspirational message, and for your leadership in this webinar series, along with Dean Charlotte Chong, who's somewhere there. Later, we'll see her. I'll go straight to the meat. You've been waiting for this. You know, the Philippine General Hospital, when it started its work on COVID, embarked on a lot of research. And very recently, they came up with a paper on infection control and keeping health workers safe. So again, an honor and a privilege to welcome our main presenter for today, who is very well known for his work in hospitals, but I know him because he plays the sax really well, the saxophone really well. So I'd like to welcome Dr. Gerardo Legaspi, Gap Legaspi of the Philippine General Hospital. Gap, good morning. Good afternoon.
Good afternoon, Susie.
Kamusta ka na dyan?
Okay naman, nakapagtrabaho pa rin ako. That's why I'm wearing this, sorry for the informal attire, but I'm here in PGH now.
Ay, nako, don't say so. Sige, go ahead, Raymond.
Yes, thank you, Dr. Susie. Good afternoon, Director Gap. We understand, so ang ganda po ng inyong t-shirt, sir, no? Pero we understand also that the Philippine General Hospital is celebrating its 113th, 113 na po, na Foundation Week. Ngayon pong week na to at ngayong araw pong ito. Ang tema po ng Foundation Day po ay tuloy-tuloy na bayanihan para sa paggaling ng bayan. Perhaps you could share po what went into the choice of that theme, Director Gap.
Well, of course, the action itself puts credence to the theme. As we have seen in the last 5 months, nothing could have been achieved without the unified work, the solidarity that went into fighting the pandemic, not only in the hospitals, but I think across the nation. So we thought that it's a good theme to remind ourselves that as we proceed with this task, there's no way we can achieve anything without being together.
Nice. Gap, can you tell us a little about the painting at your back?
Oh, that's a 1939 painting of the Philippine General Hospital. Pag nakita nyo, ang Taft Avenue, itong may brown sa near me, puro garden siya hanggang papasok. At ito'y bago magkagera. This is 1939,
right.
Signed by Arenas, but I could not find his portfolio anymore. Must be one of the Ermita painters before the war. No?
That's amazing. So Dr. Gap, can you tell us, you mentioned this was before the war. Can you tell us a little bit about PGH and World War II? Because you had the letter once that alluded to what the Philippine General Hospital did in World War II in relation to what's happening to the country right now.
I think in the history books will say that PGH in the thick of the war was the only big hospital that was left open during World War II. During the entire duration of the Second World War, where we lost some of our doctors as well. So I think the stories of those who have survived, the interns who have become our mentors eventually of that era,
Wow.
have related to us experiences like what you're experiencing now. Fear fear and the uncertainty of things, I think, are two big uh, factors that probably hampered the work that they had to do. But they got through it. They all graduated in time for them to be real doctors after the war. So I think alluding to World War II, and now brings forth the um, situation that we probably are in a war, and just like in any war, we need all the allies that we can get and all the ammunitions that we can gather to fight the battle.
Thank you, Gap. I think, well, one of the reasons why we immediately called for this meeting after you produced your paper was because there were some hospitals that had started to close down. And I think your paper is about how to keep hospital open. So we're not going to stand between you and the audience. Please go ahead, Dr. Legaspi, and you may start your presentation.
Thank you very much. If I may just share my... Is it up already?
Yes, we can
Thank
see
you,
it very
sir.
clearly.
We can
Yes.
see your slides.
So thank you again for allowing us to share our work. Let me say in advance that this is not purely PGH experience. I think in the course of 5 months and our discussions with other medical center chiefs like Dr. Balanag and Dr. Pamaran, we have gathered information that helped us put together all the strategies that we have employed, and some of them we will share this morning. I'd like to make mention first and foremost that healthcare worker safety and welfare, to say, is not a singular action. It's a sum total of these different interventions which an hospital administrator should be really wary of. No action from admin all the way to psychological intervention is independent of the other. I think if there's anything that taught us that we were taught in the last 5 months is for every action there's an exact opposite reaction, and I think sometimes we learn the hard way if we don't take special attention to this. So administrative intervention, engineering, of course, the important medical and clinical intervention, as well as those that we often neglect, the behavioral and psychological aspects of the management of our healthcare workers. Just to give you a brief background, since we already started, PGH is 113 years old, located in 10 hectares with 23 buildings, very porous borders, 1,334 beds, but at any given time we have around 1,500 admitted. In 2019 we saw 700,000 patients, half of them from all over the country. We have a huge workforce of 4,500 employees and an even bigger pool of trainees that pass our halls every year. So imagine the number of people that were in PGH that got affected, not to mention, of course, the patients and the families that were affected by this pandemic when we had to adjust PGH. It was in January 30 when, if you recall, the Secretary of Health, Francisco Duque, announced the first case of the novel coronavirus. And I think as the report of the RITM showed with the gene sequencing, they said that maybe the first two from Wuhan were really controlled because after that, there was no occurrence until March 6, which our gene sequencing, I think, showed a different kind of virus, which was more related to the seafarers that were coming in. And from then on, all hell broke loose. And then we had to declare the lockdown on March 15. So as any hospital involved in this healthcare, there's a huge chaotic situation we were in. And I think learning from from other hospitals, unfortunately, the private hospitals had it worse before the government hospitals had their turn. We learned that trying to maintain normalcy was going to be disastrous. So first thing we did, I think, and most hospitals did, was to suspend all elective admissions. And if you notice my announcement, I was quite hopeful that after 1 month, we'll be able to open everything. Little did we know that it will continue on for the next 5 months. But I think one intervention that we will be doing repeatedly, given the hammer and dance strategy, is that we will have to be adjusting our work schedule. So during that time, when there are a lot of unknown factors, we thought that reducing the workforce to a third, since we were reducing the patient's load also to almost a third also, and keeping the two teams away from the hospital, safe from the virus in their homes, would have been a good way to preserve workforce, just in case the first team gets decimated by infection. We didn't know anything about the virus, so all we knew is that if we avoid it, most probably we'll not get sick of it. So the 2 weeks adjust, 2 weeks on, 1 week on, 2 weeks off duty was the first intervention that we did, physically at least. And then in a meeting with the secretary, we were requested to be one of the 3 hospitals that were eyed to be COVID referral hospitals, serving the different quadrants in Manila, in the National Capital Region. So Lung Center was serving Quezon City, Marikina, Pasig area, and then Jose and Rodriguez was going to serve the eastern part, western part of the city, northwestern part of the city, covering Caloocan, Navotas, and PGH covered the southwestern quadrant, covering Las Piñas, Parañaque, Makati, part of Taguig, of course Manila, and Mandaluyong. So, of course, if the with the request, we could not. It's a request that we were really just happy to accede to, but of course, behind our at the back of our minds, we were thinking, how do we prepare for this? So the first thing we did was to form a crisis management team. I saw my note. Someone took a picture of the board when we were meeting that time. I think this organizational chart was very simple. Myself, Dr. Ocampo as operations chair, Dr. Serrano as logistics, Dr. Dufitas as manpower coordinator, and the rest of the hospital operations was left with Dr. Julia Cho Aguilar, who was the deputy director for health operations. So we had a bunch of surgeons working. I had the chief of trauma, I had the chief of head and neck and breast surgery, I had the chief of colorectal, the chief of urology, of course, the chief of neurosurgery, all surgical specialists operating, doing the operations, logistics, and manpower. But of course, we did not move until the science part of it was handed to us by our hospital infection control unit chief, Dr. Nina Berban. So all these crisis men were there to serve the orders of our hospital infection control unit. So the idea there was that a separate crisis management team, not in the specialty of the infectious or pulmonary or internal medicine, will unload work from those who are going to be tied down with the clinical work. So our motto then was that their wishes are our command. So I think the different aspects of operating the hospital were organized, and with the help of our dear Chancellor, we were able to create the Bayanihan na Operations Center, a 20-seat call center that's operated on the first day on March 30, and it answered queries on donations, which at that time was really pouring in more than what we can handle from our cell phones or our local phones. Also queries from patients and families about COVID. At the same time, we also organized a COVID Transfer Command Center, which I think was of the very heart of the referral center. Now, the patients cannot come in or go out of PGH without having been coordinated to the COVID Transfer Command Center, which is manned by doctors, manned by medical specialists. And I think one of the big roles of the Transfer Command is to give assurances to patients who are calling out of fear, wanting to get into the hospital, and eventually being explained to that maybe they can stay home, take precautions, and they find solace in the fact that they have spoken to the doctor, who's going to call them back the next day and the next and the next until they're better. So up to now, the COVID Transfer Command team plays a big role in the movement of patients in and out of PGH and even within PGH. So in line with that, we thought that an Information Education Committee, whose role is to constantly put out advisories and reminders, and of course appeals to the public, would be very useful. And my gratitude goes to the committee headed by Dr. Eric Berberabe for keeping everyone informed in and out of the hospital. It's very they have so far produced 700,000 of these infographics, and I think it will be the basis of some of our basis of most of what we do in and out of PGH. So we had a few days to. We were given 1 week to prepare PGH, and there were a lot of infrastructure changes that we had to do. The engineering work went at a very fast pace, and we were advised by 3 groups of architects, including those from UP and private groups. And we had to reassign patients to other hospitals, being part of the help that the DOH has extended to us. So we were able to empty our BC emergency room in preparation for COVID-19 patients that are coming in. We were able to prepare our 60-bed wards into 22-bed COVID-19 facility, which will make the care of patients easier for the healthcare workers that we have. And of course, the less patients in the ward, hopefully there were the least infections. I think one of the most important interventions that we had to do, since we cannot convert the more than 100-year-old wards with 15-foot high ceilings and wide windows into negative pressure facility. With the advice of our engineers and architects, we were able to install exhaust fans and electric fans and big blowers to give us a unidirectional natural airflow system, which achieves the principle of air exchange in the management of COVID-19 patients in non-air conditioned, non-negative pressure areas. So what we did was to blow in air into the big fans into the front of the hospital, of the wards in the pavilions. And we blew in air from the outside, fresh air from the sides, and the reverse exhaust fans with reverse exhaust fans, and the normal exhaust fans blew out air into a garden outside where continuously for 24 hours the airflow was ensured. So to test that, we put bits of papers, tissue paper on these hallways to see if the flow of air is being maintained. So you can see the paper going from one side to the other, and from the front to the back, with this main hall here being seen. So that was with that we were able to hopefully decrease also the load of the virus, which at that time was being proposed to be already aerosolized. So that was probably one of the major changes that we had to do. In the single rooms, it was easier because we just had to put an exhaust fan in one of the windows of our isolation in the pay rooms. And also we HICU scheduled a regular opening of the windows to let again to have a natural air exchange even with the air condition on. So air exchange is a very important principle of making the workplace safe, most especially if there's none of the ideal negative pressure effect that we want. So I think most hospitals adopted the zoning of their hospitals, especially the COVID wards. And one principle that I think will work, and I've seen this in other setups also, that there's a unidirectional flow of workers. When they dawn, they never go back to an area outside of the dawning. They just until they doff off from the PPE. So, of course, the level of protection was determined depending on the length of stay of the healthcare worker in the uh, COVID areas. But I think generally most hospitals in NCR or in the Philippines at that point preferred to have the highest level in any of the COVID areas that they have. So even if you can don level 3, most healthcare workers felt more secured if they were allowed to don level 4. And just to make things also again now more comfortable for our healthcare workers, at the end of their doffing area, a shower area with hot water was installed so that they can, as soon as they doff, they can take a shower and put on fresh clothes when they leave the facilities. So with all of those engineering interventions, we were able to free up 243 beds in the hospital, having promised 130 to the Department of Health. But we realized that we had to have we had to have obstetrics, pediatrics, and surgical COVID positive beds. So that took a lot of the beds also from our usual assigned beds for COVID. So we had to open up areas so that we can ensure that there are enough beds for the adult medicine COVID-19 cases. So to this day, we maintain these beds for these various types of COVID-19 patients. Of course, there's no way to prove what you've done to be right until you test it yourself. So I must tell you that it's not easy to be in the PPE. I think it's to imagine our workers lasting for 8 hours inside it will be an understatement. So after all the preparations were done, we declared the PGH, the Philippine General Hospital, as COVID-19 referral hospital in March 30. So from then on, we have gone to more than 4 months now, going to the 5th month. And you can see after the initial preparations, the ventilation, the acquisition of at least 1.5 months of PPE in advance per a month, adequate manpower, and with the assistance of the Department of Health again for additional volunteers that came, we opened and served our mandate for COVID-19 patients. On the 8th week, after 2 months of being COVID referral center, when the numbers were going down after the strict quarantine protocol, we saw more patients coming in and more staff coming in. So we were starting to plan on resuming operations of the hospital. And that's also when we started to plan for hospital-wide surveillance testing, having opened our own molecular laboratory for COVID-19 testing. We thought it was a good time to evaluate what we have done in the last 4 months. And we did that in the last 4 weeks, 2 months. And we did that from June 1 to 25, of which I'll show you the result later. Little did we know, as more COVID, as more patients and staff were coming in, and more community transmission was happening in July, we experienced more COVID infection in the hospital. So that's going to be part of the lessons that we're going to share with you in terms of healthcare worker safety and infection. As of today, I'd like to show you some of the infographics that we have put out on a daily basis, and how the numbers have increased from a low of 100, or maybe there was a time there were only 70 in around the later part of May, and it started an increase at the end of June, peaking at the middle of July and to the third week. And now our last infographics today from yesterday was 183 patients admitted. We have in total have admitted 1,379 patients. We have had 454 COVID healthcare worker infection, the majority of which are those not involved in direct COVID care, and this is in the span of 4 months. Our mortality rate has gone down significantly in May and June, and it started to increase again in the end of July and in August. So patients are coming in more sick. I think the fact that more ICU beds are being utilized now prove that more patients are sicker at this point than they were in the first 2 months of our operation. So as we review our outcome, we are happy to note that a great majority of our patients are able to recover and go home from this COVID infection. So what it has affected a lot, all hospitals, I think. COVID infection has practically reduced a big government hospital like ours to a third, less than a third of its operations. So for now, we have around 420 beds on a daily basis open, and half of them are dedicated to COVID-19 patients. This graph just shows you how dramatic the effect of running a COVID hospital referral center like ours in terms of surgical output. So on the average, we do around 2,000 to 2,500 operations a month. And now we're at our best in June and mid-July. We're down to a fourth of that. So I think it is easy to see now how much, as Secretary Duque has mentioned earlier, how much big effect it has, not only not only for those directly infected with COVID-19, but also those that collateral damage of having missed the appropriate health care that they should have gotten. So you just see here how much percentage of our operations are affected by attending to COVID patients. So in the early part, of course, it was the peak of the numbers coming in, with the second one coming in the in the month of July. So this is the number of patients that are losing their opportunity to be treated as well for the non-COVID illnesses that we usually see. So from all of these events that have happened in the last 4.5 months, I think sharing with you the lessons we've learned will be something that we'd like to do, of course, and hopefully make everyone realize that there's no playbook to start to begin with in this, and that what we probably have learned has also been the experience of other centers handling COVID-19 referral patients. I just like to make mention also that if some of the ideas sound perfect, it just proves that the hindsight is really 2020. So a lot of these lessons were learned in a painful manner, and I hope The boards, the way they're presented now doesn't underestimate the sacrifices of the different people who have gone through this experience and served the patients in the COVID wards. I think the most important lesson that we should remember in this whole operation is that people are our most valuable resources. So I think um, we underestimated the fear that was associated with COVID-19, and managing fear, not only of our own fear but of other people around you, probably was one of the biggest hurdle that we had to get over before we can do all the rest that we needed to do. Uh, to do this, we had to keep them informed of the latest about the disease and about the interventions they're going to do. Of course, we had to keep them, make them feel protected and comfortable by giving them the assurance of the proper PPEs, by giving them housing and transporting them to and from work, just to have that the feeling that it's going to be available to them. I probably will lessen their anxiety and their uncertainties of in the work that they have to do. And I think in the last 4 months, 4.5 months, an important lesson that we have learned also is that at the beginning, if I was a general giving orders to my soldiers, I think to make this war last longer, if to make our troops go for a longer time in this war, is to make them partners as in a cooperative. So these are strategies that were learned painfully um, through the months that we've been operating the COVID wards. So to help them overcome their fears, I think the important thing is that they're not alone. They have to be uh, they have to feel that there's a community behind them. That's why we had this poster printed out of isang bangka tayo, because whatever kind of work you did in the hospital, we were in the same boat. So residents, nurses, workers from other non-IM departments, non-internal medicine departments, pitched in to the work of the internal medicine. Even the dermatology department had their role in the COVID wards. So psychiatry sent their residents to man the stations in the COVID wards. Surgeons and neurosurgeons went to the ICUs handling the COVID wards. So I think that sense of community will help lessen the fears of our healthcare workers directly involved with the patients, and modifying their work schedule to ease up, give them time to recover. Also help in the protracted war that they are going to face. As of now, the COVID ward workers are on a 1 week on, 1 week off schedule. The nurses being in the actually in the putting in more man hours than anyone else in the operations, even have a 1 day off in the 7 days that they are in the COVID wards. No? We are happy to note that the Department of Health has generously supported us in many ways, including sending 98 DOH volunteers, doctors, nurses, technicians, and admin office staff to help us augment the workforce that we put in the COVID wards, and help us operate the non-COVID wards as well. So as I said, they have to be, our employees, our healthcare workers have to be constantly informed and reminded. So those from the very simple safety reminders outside of in the workplace and outside of the workplace, and also the daily steps that they have to take to ensure that their exposure is documented and duly noted, so that we can intervene early also. So It also helped that one of the interventions that was well received by our healthcare workers was the presence of safety officers in the donning and in the doffing. So I think especially during the early part of the operations, the safety officers um, made sure that all the steps necessary to have a proper PPE worn are there, and they were given regular lectures and reminders on how to ensure this. It helped also that our safety officers were our dermatology residents, some of them, and they were able to give instant dermatologic advices to those personnel whose N95 mask somehow caused blisters on their faces. No? So I think this is one aspect that was really appreciated by uh, our COVID workers. We also ensured, even if you're using N95 masks, that the fit was good, because not all faces are the same. Not all masks will fit the same face. So I think this is one step also that will help reduce the accidental uh, contamination of our workers from the air that they breathe. So this is something that is done regularly. Now that we're shifting slowly to elastomeric respirators, even those, even if the fit seems good, we still do our fit tests for the elastomeric respirators. And of course, we have to remind everyone of the proper PPE. It was a source of anxiety at the beginning, because everyone wanted to be in level 4, whether they were COVID or non-COVID workers. But of course, it was not possible. So I think with constant reminding and very clear messaging, we're able to now at least convince them that they don't have to be in a higher level than what is necessary in their work area. But we have probably one modification that is not found in other recommendations, which is a level 2.5 in our non-COVID wards, where a patient can be occasionally be positive. Accidentally, we discover that they're positive. So we use a fit-tested KN95 mask for these areas. Of course, it's not enough to protect them. They have to be comfortable and and assured of proper accommodation. So we provided them with transportations of all kinds, from shuttle buses to bicycles for those coming in from near the facilities near PGH. And at one point, we were housing 1,800 healthcare workers in 15 hotels, 10 schools, and religious dormitories. We're now down to 1,000, and I think with the uh, approval of the Chancellor, we are using more of the UP Manila college facilities, auditoriums, conference rooms, classrooms, which is favored by our healthcare workers, because they just have to walk to and from PGH from those facilities nearby. Although we still have our hotels and our dormitories for the rest of the healthcare workers. So I think the other aspect of, as I said, of the making them, ensuring the welfare of our healthcare workers, is to assure them that we are also taking care of the other problems associated with this, the work that they do. As I said, from dermatologic concerns to psychosocial care, and even our spiritual care through our telechaplaincy is being done. And our chaplain, Father Lito Ocon, actually dons PPE um, regularly to talk to healthcare workers as well as patients. So, and he gives us feedback on what the healthcare workers' concerns are when he has the chance to. As a probably as an intervention for a longer time, I mean, for a more protracted war against COVID, we are in the we have just started building our COVID-19 isolation complex, a 44-bed isolation complex with 11 ICU capability and air pockets so that healthcare workers do not have to be in PPEs to see their patients, and organize bed assignments so that monitoring of patients would be easier. So we will have the ideal negative pressure uh, uh, setup with a air exhaust system that is HEPA filtered and treated with UV light. So I guess later on when the COVID-19 patients still come to PGH but in a lower number, we can truly isolate them from the wards and operate the wards regularly as we had in the past. So this is in preparation for a longer presence of the virus in our hospital. So I think in order to limit infection of our healthcare workers also, we have to be very active in contact tracing. And one of the principles that we have reported in that paper is that contact tracing doesn't start when you find out someone is positive. It starts when you suspect or when you hear of an exposure of a healthcare worker. There's a clear example of this when one healthcare worker went to the health service to seek consult, but was not able to get hold of a doctor. Went back to his office and then to his dorm. Went back the next day, and then that's the time he was seen, and then later on tested positive. And there were 37 people who were traced to have been exposed to him, and I think 13 eventually became positive, and they're all admitted. So I guess it's really important for our healthcare workers to understand also to report, so that we as soon as they feel something or as soon as they suspect that they've been exposed, which is the essence of a good contact tracing system. So in order to even enhance our ability to do that, we had area unit managers, the head nurses, to be facilitators of reporting, and office administrators to do the actual to help with the actual tracing of the contacts, of course with the guidance of our hospital infection control unit. It is difficult to relay all of these complex concepts to our all kinds of to all our healthcare workers. So again, with the use of infographics, we try to make them understand the infectiousness of the virus, so that they themselves will know how to report people who were exposed to them or who they got exposed to also. That it starts the infectiousness of the virus starts 2 to 0.3 days prior to the onset of the symptom, peaks at 0.7 and declines within 7 days. So having that in mind, I think it's easier for us now to get the right answers from our workers when we are asked them about, when we investigate about exposure to the disease. So definitions are also made clear by defining contacts being from asymptomatic to symptomatic ones, and they're all available in infographics that we are issuing regularly and sometimes repeatedly to the healthcare workers. But I guess no, nothing will beat going down to them and explaining, as our health service consultants do, when they give the advice directly to them and reminds them of the different interventions that need to be done. So one of the I think one way to ensure proper management of healthcare worker infection is to have a dedicated health service doing this. So our Department of Family Medicine, Family and Community Medicine consultants and residents take care of this solely for now. And I would like to make special mention that they're doing a good job helping us control this infection in healthcare workers. So going now to testing, I think we have made a statement in that paper that although we were able to do mass surveillance of our employees, 4,871 of them, our conclusion from that experience is that targeted testing, as provided for in the guidelines of PhilHealth and DOH, is still the most optimum for doing this test. No? It took us more than 3 weeks to complete testing 4,800 employees. So if we do that every 2 weeks, we'll be doing nothing but to test our employees. And also, we also tell people that testing is just a point in time, and that maybe if you test negative today, it doesn't ensure you that you're not negative. You're still negative the next day or the next week or the next month. We don't take the proper precautions. So I think what we just did, because people still feel like it's a privilege or it's a right to have regular testing, we just explained to them that we will just lower our threshold for testing. If you have the mildest of symptoms, you come to the clinic, and we will schedule you for testing after that. So we also remind them that the timing of the test is important, because the best time to catch an infection, if it has really been transmitted, is around 5 to 8 days from the time of exposure. So this lessens the insistence on some of the healthcare workers to be tested right away. So I guess the information regarding this really has to be shared regularly also. From that surveillance test, we found out with the first 3,033 patients that we did, that the concordance between rapid antibody testing and those testing for positive was only 20%. So that's why we made that recommendation and the suggestion that it should not be used for screening or deciding who is positive or not, and allowing them to work because of the high probability of being false negative. So I think if there's any message from this surveillance testing that we did on our healthcare workers, is that rapid antibody testing should be used as more for surveillance after the disease, and in our case for screening our convalescent plasma donors as well. So we use it to protect our healthcare workers by doing outpatient swabbing and learning from the data that we get from that. So we have established an open-air outpatient swabbing, either walk-through or drive-through. And we have mandated that no patient and watcher gets admitted for an elective or emergency admission until they are negative. So we are able to put out result in 24 hours in most of our cases. And we have the ability, having had the donation from ABS-CBN of our BD Max unit, which allows us now to put out results in 3 hours. So we are very thankful for this machine, because it has simplified our emergency admissions greatly. So again, we remind our healthcare workers on who really needs to be tested, so that their fears are overcome. Because you can imagine demanding testing when there is an exposure, let's say in the dormitory or at home. So we have to repeatedly tell them on the types of exposure that they have and the severity of symptoms that they will eventually manifest, on who gets the priority for testing. So it's important for them to understand whether they're low risk, medium risk, or high risk. So, and we have described all of that in the different infographics that we put out. So the result of that hospital-wide surveillance showed that our healthcare workers had very low infection rate at that point from July 1 to 25 with a 2% overall. And it was surprising to see that those working in the COVID wards had the same had the same risk for those not working in it and those only supporting them. So this has given us some feedback, a good feedback that the interventions that we do in the COVID wards help prevent infections of the direct infection of the healthcare workers. Uh, in that surveillance, also doing simultaneously of those symptomatic ones. So these were the asymptomatic patients that were tested. The infection rate in symptomatic ones is 4.7%. So while we were with that result, we were about ready to give ourselves a pat in the back. But lo and behold, at the start of July, and the uh, declaration of general community quarantine, we saw a rapid rise in our healthcare worker infection, and this was mainly due to the exposure in the community. So there was a 10%, almost 10% positivity of healthcare workers that we tested in our that sought consult in our clinics and eventually tested. And again, our data shows that most of them were from outside of the COVID wards direct care. And this is when we realized that we also had to protect PGH from the community in the same time that we are protecting our healthcare workers from our patients. So we had to do a lot of behavior management and, of course, a lot of contact tracing to limit the exposures. This is when we launched our Lakbay Alalay kit, providing face shields and a box of face masks for a whole month's use that they use to and from going to work and walking and to and from the hospital. So we're happy to note that the infection has started to go down by the second week of August. And there is now less positivity of infections, of testing of our healthcare workers. So these interventions and the constant reminders of the protocols do work. So in closing, I just like to say that as mentioned by the Secretary, that our activities or interventions that we do in the hospital should be really science-based, because it really works. Science really works, but we must exercise discretion on what science to believe in, and I think that's where the experts come in and guide us on the things that we need to do. The basis for innovation is guided by our expertise and, of course, existing data. But the most important thing is to bring all of this science down to the ground that will benefit our healthcare workers. So in our preparation to go back to GCQ, we put out a guideline for with the 5 pillars of hand hygiene, physical distancing, self-monitoring, clinic symptomatic and temperature-wise, of course, wearing of the mask. And I guess at this point, we have to introduce now the culture change that we'd like our healthcare workers to adopt. That we embrace a culture with a desire to keep others safe, not just ourselves. So with that, I'd like to part with these 3 words from the WHO that we go through this pandemic together in solidarity, using science to have the solutions. Thank you very much to everyone, and good afternoon.
Thank you very much, Dr. Gap Legaspi. Let's see. Thank you, Gap. I think we're really in a historic moment, and when the history of this period is written, you will be remembered as the director of the Philippine General Hospital and all the sacrifice that you've put into the work. We know it's not been easy, but your leadership has really made a difference. So thank you, Gap. Okay, let me quickly introduce our other speakers, because while PGH was taking care of some quadrants of the NCR, we had 2 other hospitals that we're also getting filled up. And I'd like to welcome to our panel Dr. Vince Balanag, the Executive Director of the Philippine Lung Center, handling that particular part of the NCR, and Dr. Alfonso Fritz Famaran, who has also joined us from Jose N. Rodriguez Hospital, used to be Tala Hospital. So, gentlemen, welcome to the webinar, and we're going to get quick reactions from both of them, and then we're going to go into our discussions. Okay, so let's hear a few words first from Dr. Vince Balanag. Vince, go ahead, please.
Pleasant afternoon to everyone. It's really a real pleasure and honor to be invited to this national webinar on safety of health workers. And thank you, Dr. Susie, for inviting me. Okay. So,
Go ahead and share your slides, Director
okay.
Vince.
Before I share my slides, I'd like to congratulate Dr. Gap for that comprehensive presentation. Very informative and interesting. I would say I could truly relate to everything that Dr. Gap has presented, as we in the Lung Center are facing the exact same challenges as PGH is confronting. And many of the actions that PGH has undertaken are the same of what Lung Center is doing. So allow me to present some of the things that Lung Center is doing so that maybe the others can learn also from our experience. For those not familiar, Lung Center is one of the 4 corporate hospitals located at the heart of Quezon City. No? So we're serving the northeastern part of NCR. No? LCP is not as big as PGH. We're just a 250 bed hospital, which during the pandemic has been reduced to 170. So we're having 120 COVID beds and 50 non-COVID beds. So we're still serving non-COVID patients. Our hospital staff also numberless. We just
Doc Vince, do you have slides for what you're talking about right now?
No.
Not yet. Okay, go ahead. Sorry, I thought the slides were delayed.
So we're about 900, including plantilla, job order, and we have some augmentation from the DOH. You might say that Lung Center had some previous experience with fighting diseases with pandemic. No? So we have been designated previously as a referral center for emerging and re-emerging infectious disease as early as 2003 when we had the SARS epidemic. And again in 2009 during the H1N1 epidemic, and most recently the 2015 MERS-CoV health problem. So more or less we have some experience in dealing with this, but definitely not like what we're having right now with COVID-19. So as of now, our imperatives really is to be able to cope with the increasing number of cases we have, just like in PGH, and managing to keep our health workers safe, healthy, and happy. So I will now share my slides. Okay, so this one would be the slide of our admissions as well as our bed capacity. So when we were assigned as COVID hospital, we just committed about 40 beds.
Doc Vince, wala pa yung slides nyo.
Oh.
Oo. Let's put it on...
Share, no?
Yeah, go to share screen.
Sorry. Oops.
Doc, we also have the slides with us. Would you want TVUP to put them up?
Yeah, yeah. Okay.
Okay, let's see if TVUP can be the one to put it up, or is it Raymond? TVUP.
It's
Okay,
TVUP.
there we go. Okay, there we go.
So you would see this one would be our COVID census and bed capacity over the since April up to August. No, you would see that at the start of the COVID pandemic, we just allotted about 40 beds, but right now we're already allotting 120 beds. So the green lines would show you the number of cases we had during that period. We did see several peaks and valleys, no? And you would see that even during the ECQ and ECQ, more or less, we had a moderate number of cases. No, actually, even in the middle of the GCQ, we really have a plateau here, wherein we just have less than 40 cases. But after that, really the cases began to spike. Up to the present, we're still about 90 to 100% capacity. Now, in terms of bed capacity, every time there was an increase in the cases, we managed to increase our bed capacity by adding additional wards as COVID beds. No, the other way is to cohort our COVID patients, meaning they're sharing beds for those who are mildly sick or asymptomatic. Then, of course, after that, we had really to increase our beds so that right now, as I've said, we're up to 120 beds. And most of it, 90% to 100% full. Next slide, please. Next slide. I'm not controlling my slide, so could you please? Okay, yeah. So, well, our cases, COVID-19 cases are quite moderate or modest. Even during the early periods, we just had a few COVID cases. And actually, during April, we just had 2. And we had a 30-day period wherein even with COVID testing of our frontliners, we just had 2 during that time. So 30 days without any new cases from our health workers. However, when the restrictions have been loosened, then we actually saw a gradual increase in COVID cases among our health workers. And this is quite problematic for us, especially when you look at the profile of who are getting sick. In August, we just have 11, but I think another 8 has been added here to make a total of about 73. So this would be a breakdown of the 66 health workers that got sick during that period. You would see that among doctors, we just had 7. And most of those in COVID areas, the nurses are the one affected. But again, you'd see that nurses working in the non-COVID area are more than those nurses working in the COVID area. So that tells you that maybe really there's some community transmission going on. So in terms of med techs, radiologists, and pathologists, we are having just a few cases. But what is interesting is the non-clinical COVID areas had got more cases, the engineering, the dietary, and the janitorial, which understandably they go into the COVID areas to service. But apparently, most of these infections are due to those gotten during when they get together while eating or during conversation. So these are the matters we have to consider when advising them. So also we have a few coming from the non-clinical areas, and we think that since they are not exposed to COVID areas, then they're probably gotten it from the community also. So just a reiteration of the important things we have been doing to keep our health workers safe. Of course, the importance of personal protective equipment, ensuring an adequate supply of all types of PPEs. No? So during the start of the pandemic, we really had problems sourcing out personal protective equipment, but we were able to cope because of a lot of donations from various groups, both private and government. Just like in PGH, we ensure strict donning and doping procedures, doing continuing orientation and monitoring of our health workers. And also we have separate dedicated donning doping rooms in all COVID areas. Now, in terms of engineering controls, I think this is for us the game changers. No? So we attribute this to the as the cause of the very low infection rates in our COVID area. So we installed air cons and exhaust systems in all COVID rooms to maintain the prescribed air exchange. No? So we don't have large wards like PGH, but we have individual rooms having from 1 to 6 beds in a room. So because these are enclosed areas, it was easier to install exhaust systems and ensure the adequate air exchange. Also, we equipped many rooms with CCTV and remote vital signs monitors, which are connected to the central monitor in the nurses station. This allows less contact between the patients and their health workers without sacrificing the treatment of these patients. And our staff communicate through handheld radios so that they won't really have to meet each other to be able to communicate. Also, we remove all the doors in these rooms and replace them with plastic sheets to facilitate entry and exit of our health workers. And also we had a one-way flow of traffic separated by plastic sheet barriers. In terms of administrative measures, screening and cohorting patients are very important. No? So that is because we handle both COVID and non-COVID patients. So in the ER triage, there's already a system wherein unless you have a swab already showing you to be negative, you have to undergo the same procedures as COVID patients. Only when you are found to be negative that you are transferred to the regular ER and finally admitted to the non-COVID ER. Also, we designated color-coded zones with strict implementation of proper PEP use as well as waste disposal. Just to give you an idea of what these zones are, so this is more or less the floor plan of our ground floor. So blue zones are actually the general areas wherein you just have to wear face mask or a face shield. No? Then we have the yellow zones. These are the diagnostic areas wherein you have to don additional protection like gloves or even body suits. No? So these are the laboratory, the x-rays, as well as the regular ER here. No? Now, the red zones are those who are harboring patients who are COVID positive. So this red zone here is actually the access from the ER of all COVID patients. So there is a narrow way wherein all patients should be transferred to the COVID wards. And this one is our elevator. No? These other red zones are the morgue, and this one is a COVID laboratory with access from outside. Then here in our second floor, again, we have the blue zones. And now we have the yellow zone here, which are the ORs and the endoscopy room. And the red zones will be the medical ICU, as well as the COVID wards 2A and 2B. No? So these are contiguous areas wherein strictly there's restriction of all non-COVID personnel or patients. Then we have the orange. This particularly our hemodialysis unit, which has ready access to the wards, because most of our patients also, aside from having pneumonia, also require dialysis or hemoperfusion. And finally, we have the administrative measures. We also have a safety committee with designated safety officers in both clinical and non-clinical. So we have safety officers in all offices, and these safety officers are the one doing daily symptom monitoring and temperature check to make sure that none of them are possibly COVID. And these are written down and submitted to our HR every day and submitted to our safety committee and employees physician. For all our health workers, we do, whenever they have symptoms, we immediately swab them together with everybody in their office or in their ward. And we try to quarantine those who are symptomatic until we get the results. Otherwise, those who are asymptomatic get periodic swabbing every 2 weeks for the COVID areas and every 4 weeks for the non-COVID areas. Just like in PGH, we provide them shelters through hotels. We have several prefabricated dorms donated by the Office of the Vice President, DPWH, and private groups. And we also have people being sheltered in UP Diliman, particularly NISMED and the College of Human Kinetics. And we also provide transport. We have our own vehicles, and we also rent vans. And we were given or loaned Egypt by Hino. And we also had bikes, and recently we have Angkas services provided for free for our health workers. So these are the things we're trying to do for our health workers to keep them safe, because after all, as Gap had said, our health workers are our most valuable resource at this time of pandemic. That's my last slide. Thank you.
Thank you very much, Vince, for that concise presentation. I think a lot of similarities with what Dr. Gap Legaspi presented: administrative engineering measures, zoning, even transport. So I think this is really an excellent opportunity to hear what our hospitals are doing, because the public don't see that. No, they don't know it. They can't see it. But just so much work that goes behind just keeping one hospital running, right? Before we go into any questions, we also have Dr. Alfonso Fritz Famaran from another huge hospital, from the Jose Rodriguez Hospital. Fritz, there you
Yes,
go.
ma'am. Good afternoon po.
Hi, good afternoon, Fritz. Welcome to the webinar.
Good afternoon, ma'am.
Please go ahead
Yes,
with your reaction and sharing.
On my submitted slides for discussion, I
Okay.
think around 3 or 4.
So let's see if we can.
ask TVUP to display them, Director Fritz. Okay, I think your slides are now on the screen, Director Fritz. Go ahead.
So good afternoon, and I'd like to congratulate Dr. Legaspi for taking care of the healthcare workers of UPGH. And I will not go into the measures, since almost all of the measures are quite similar with that of UPPGH and that of the Lung Center of the Philippines. Dr. Sen Rodriguez Hospital and Sanitarium is quite different from UPPGH and the Lung Center of the Philippines. This hospital is a national government hospital which caters only for COVID-19 positive patients, moderate to critical cases. Next slide, please. Okay. These are the reporting system being done by the National Government Hospital, a daily reporting system which we submit to the Department of Health. The authorized bed capacity of our institution is 800 beds, and the COVID-19 positive beds or isolation beds is 500. So that's 500 over 800. For this day, we could see that the COVID-19 positive patients admitted is around 188, and the COVID-19 related cases are 199. If you'll ask why do we have suspects and probables, these are the healthcare workers being admitted to the institution for treatment and monitoring. Now, I'll be basing my discussions on the green table. Is the healthcare work status as of August 18, 2020. You can see here that the total healthcare workers that were affected is around 102, and the active cases as of August 18 is 24. Next slide, please. So from March 28 to August 18, the total COVID-19 positive patients that we had was around 1,090. And the total COVID-related cases around 1,202. And the next table would show us the healthcare worker status, which were discharged from March 28 to August 18. That would be around 78. Next slide, please. Okay, so these are the breakdown of the manpower complement of the institution with a total of 1,700. Next slide, please. Okay. If you can see the computations for this institution, as per the total number of hospital staff, 6% of the total number of hospital staff were infected with COVID-19. For the total number of COVID-19 positive cases, 9.3% of the total number of COVID-19 cases were healthcare workers. As to the total of COVID-19 related cases, 8.4% of the total number of COVID-19 related cases were healthcare workers. Next slide, please. So the measures or practices being done by PGH and Lung Center of the Philippines mostly are being done in our institution with some additions. So to make it short, I'll be running down the list for brevity. So number one, all COVID-19 positive healthcare workers, moderate, severe, and critical, it's mandatory that we admit them at the COVID-19 wards. For COVID-19 positive mild healthcare workers, we admit them at the hospital quarantine facility. For healthcare workers probable suspect mild cases, we admit them at the hospital infirmary. Once with a negative swab, we send them home for home quarantine. Yeah. Number four, all healthcare workers probable suspect moderate, severe, critical, mandatory that we admit them at the non-COVID wards. For ease of monitoring and communication, circuit television monitor donning and doping areas were installed, including the isolation rooms. The operation we had 3 operation centers for this. One at the nursing operation centers, the Health Emergency Management Bureau Operation Center, and one at the Office of the Medical Center Chief. 6 safety officers are present at the donning and doping areas. Next slide, please. 7, just like UPPGH, we follow the 7 days COVID wards duty and then 14 days hospital quarantine. Before leaving the hospital quarantine, for monitoring purposes, we do a swabbing test. 8, wearing of the medical grade level 3 PPEs is limited only to 4 hours. We found out that in our institution, wearing this level 3 PPEs for more than 4 hours resulted to an increase in number of healthcare workers being infected. Number 9, swabbing of all healthcare workers, staff, personnel, and immediate family with symptoms, wherein the release of the results is within the day using the gene expert PCR. Number 10, hands-on management of the consultant staff for COVID-19 positive patients, suspects, and probable. 11, COVID-19 training unit weekly orientation of healthcare workers prior to COVID-19 wards entry. And lastly, pre and post duty medical evaluation is mandated to all healthcare workers prior to entry to the COVID-19 wards. That is all. Thank you.
Hey, thank you very much, Fritz Famaran from the Jose Rodriguez Memorial Medical Center, which is a completely COVID hospital, which has also been accepting a lot of patients in the past few weeks. So I'm going to turn over to Raymond because we actually have some members of media who are joining us. So I'm going to ask all our panelists, Dr. Gap, Dr. Fritz, Dr. Vince, to open your cameras and your mics. And we're going to ask our guests who Raymond's going to introduce to field their questions.
So thank you, Dr. Susie, and thank you for the wonderful presentations from PGH, care of Director Legaspi, from LCP, which will be from Director Vince Balanag, and from the Jose Rodriguez Memorial Hospital, which will be from Director Fritz Famaran. We also have, I think we are still privileged to have Secretary Duque still on the panel. Secretary Duque, are you still here po?
Yes, I think he's there.
Yes.
There.
Yes. I came back.
Thank you, Secretary. So we'll just start the ball rolling with the questions. I think the first questions po, may we call on the President of the PGH Physicians Association, Dr. Jella Villa, to ask her question po. Dr. Villa, can you unmute yourself and maybe show your video po before you ask your questions?
Hello po, good afternoon. Good afternoon to our speakers and to everyone who are watching this webinar. Congratulations po, Sir Gap, on your insightful report of the PGH experience as a COVID center, as well as to Dr. Balanag and to Dr. Famaran. Sir Gap, you mentioned po that we must listen to the healthcare workers because we are the most valuable resource during this pandemic. The PGH residents and fellows are your foot soldiers, so to speak, along with the nurses. So my question would be, how is the PGH administration able to ensure that the administrative decisions are not divorced and are actually in tune with the clinical realities that the healthcare workers experience on the ground?
Thank you very much for that question. I think, as I told you, we found out in the painful way that this is something that was overlooked at the start. No? As I said, I was a general ordering everyone around at the start, but eventually realizing that as an important part of sustenance of this war, we had dialogues with the residents and two major departments now, internal medicine and obstetrics, and it is amazing what type of what input you can get from those meetings. And since that time, at least for the residents' part, we asked them to be part of the crisis command committee already. So inputs are given directly to us during the meetings from them. The nurses have their representatives that discuss strategies with us. And of course, through the PGHPA, we're able to disseminate this to the others. So I think for all hospital managers or directors, this is a way to be able to sustain everyone by getting inputs that actually uh, is a big factor in implementing ways that will make their lives better, at least in the hospital. So I think we employed a few. We call it a COVID dialogo. We had the Facebook Live uh, presentation of some of the policies. And then as of late, we started having our virtual flag ceremony, and hopefully through that also we're able to convey messages to our health workers.
Okay, thank you.
Did you have
Thank
another
you.
question, Dr. Villa, for Director Gap or for any of the hospital directors?
No, I'm good na po. Thank you po.
Thank you. For our next person to call
Dr.
on,
Sarmiento, Dr. Sarmiento.
Go ahead, Secretary Duque.
Yeah, kung nagpa-flag raising ceremony kayo, of course, I assume may physical distancing, but normally, bawal yung mga mass gatherings. Kung I suggest you give certificates siguro every Monday or Tuesday to those that have worked extraordinarily well, yung mga healthcare workers. A certificate would always be a good morale booster, or some other incentives so that the level of performance is up. Thank you.
Thank you, Secretary, for that insight. I think I will have more questions primarily directed for our Secretary. May we call on Robbie Alampay from the Chiefs po.
Hi, magandang hapon po. Before anything else, thank you for having us here, and saludo po sa lahat ng ating frontliners. Really a very heroic effort on your part. I'll have two quick questions if you don't mind. One is obviously the big context to what we're discussing here right now is also partly we are re-emerging into GCQ and exiting also the timeout that the frontliners had asked for some weeks back. So of course, the first basic question is, especially Dr. Gap, given what you mentioned that you did notice a spike entering the GCQ before of about 10%, that had to do mostly with community exposure, and as well as noting yung occupational exposure. What are you bracing for now that we re-emerge into GCQ? And the second question is if you could just help us to fully contextualize, speaking of our frontliners, the situation with our nurses. Government earlier this week suspended the deployment. I think as of yesterday, they've lifted that suspension. So, but ang magkabilang party po nung that dilemma was, on the one hand, giving the impression that we need as much of our manpower here at home. But on the other side of it, if I remember correctly from our conversation with the Philippine Nurses Association, they said that actually we can still afford to let people pursue their opportunities abroad, and we will still have a surplus of 200,000 nurses in the country that are actually unemployed. So we're trying to reconcile, first of all, what's the premise when it comes to our nurses in particular? Is there a shortage or is there a surplus? And how do we reconcile the dissonance there and the gap there? If there is a surplus, what is keeping us from, why is there still a shortage on the ground? Is it pay? Is it benefits? Or is it fear as well, as you had alluded to as well, kanina?
So for the first questions about the GCQ, a stricter quarantine and being relaxed, I think there is no doubt that historically the data has shown that a stricter protocol does decrease the virus transmission. all the data of the three hospitals have shown that. The increasing numbers, whether healthcare workers or patients, of course, also correlated with the relaxation of the protocol. We cannot. I don't think. I think at this point, the delicate balance of being able to open up the economy and the again, on the other hand, being able to take care of who get sick because of doing that still is being studied very well. I mean, the experiences are being digested, and hopefully in the long run we get to, so to speak, live with the virus. So as far as the hospitals are concerned, I think more and more hospitals now are capable of handling COVID-19 patients. In fact, I don't think there's anymore a COVID referral center because all hospitals are taking at least 20 to 30% COVID patients. So this is a reflection of the fact that in the last 5 months, more hospitals have already been capacitated to do this. No? Of course, how much more will come in the next month or so when we relax, we don't know. But I think the lessons we've learned so far will help us get through this, being a COVID referral center for 5 months. So definitely a stricter protocol will help, but our role is to so to speak, take care of the wounded in the war. The real war is in the community. I guess that's where we have to really concentrate now.
Okay. Thank you very much, Dr. Legaspi. I think, Robbie, you had another question about the nurses. Did we want to, I don't know, did we want to direct that to Secretary Duque? Maybe, right? Robbie?
Whoever, I'm
Yeah.
not directing it to anyone in particular, but ayun lang, just to repeat that it's just trying to reconcile because we're hearing both sides and I understand that it's a dilemma. But one basic premise is there's a shortage on the ground. But part of the premise as well is that the nurses are saying, no, we actually have a surplus of nurses that are actually unemployed. So how to reconcile those two? And what is the proper way to frame this moving forward?
Okay, I think maybe that's for Sec Duque. Sec, are you there?
Secretary, maybe we could ask you to answer that question, sir. Just to piggyback on
I'm
that
here.
question.
I'm here.
Opo.
Yeah.
Secretary, just to also piggyback to the question related to the nurses, one of the questions also have been any comments with regards to the comments from our group of doctors to the barrios who have been, shall we say, requested to help out by leaving their posts. What will be the outcome po from in terms of their original postings and that sort of disconnect, shall we say, with regards to the request po, Secretary?
Well, let me address first the question of Robbie. Hi, Robbie. Yung dissonance that you were talking about, that on the one hand, we're saying that we're letting our some nurses, hindi naman maramihan. Ang alam ko, the IATF decided yesterday na yung may mga live or pending contracts with their employers abroad, yun na yung pinahintulutan na lumabas. Yung naman pangailangan, malinaw naman yun eh. Kailangan talaga natin ng mga nurses. Yung nga lang, maraming factors, no? Like yung nakausap ko yung ibang mga private hospitals na ang sinasabi ng kanilang mga directors, mataas yung attrition rate. It's not because kulang sa nurse, kundi marami din ng mga magulang na ayaw na nilang pabalikin ang kanilang mga anak na mga nurses para magtrabaho sa mga ospital dahil yung takot at kaba na baka mahawawa sila at hawaan din ang mga kapamilya. So maraming ganon, yung attrition rate mataas. So we just have to constantly communicate that the protective measures are in place, like adequate PPEs at the different grades of quality PPEs. No? And then the infection prevention control measures are also in place. The protocols, the guidelines are there for implementation. But implementation is where the weakness sometimes is seen. Dahil kaya kailangan mo monitoring, no? Yung
Sec,
standards.
sorry, they're asking to open your video so they can see you. I'm very sorry to interrupt you.
Yeah, I'm sorry. Okay, I
Okay.
thought...
There. Okay, okay na po. We can see you.
Pasensya na,
Sorry.
nakamasok ako because I'm on quarantine now, no? Oo.
Oh, ganun ba? Oh, sige po.
Yeah.
Go ahead.
I was with Sec Ed for 3 days, Anyo.
Oh, goodness.
So,
Okay.
yung atin mga nurses, hindi naman meron tayong shortage. May surplus nga. Tama naman yung datos na 200,000. Yung nga lang na nagiging problema talaga, according to some private hospitals, yung mga magagaling nila na ensayado na, trained na, matagal na andun sa kanila, yun ang mga pinipili ng kanilang mga ahente o mga employers abroad. So, ang nangyayari, parang springboard lang. Yung mga hospitals, magte-training sila, tapos lalabas, ganun ang ganun. Pero sa panahon ng COVID, talagang sabi nga ni Pangulo, we cannot afford naman to let our nurses, if many of them are leaving, parang mahirapan naman ang taong bayan dahil kinakailangan pagsilbihan nila ang taong bayan dahil gaya ng sinabi ko kanina, sino ba mga ngalaga ng Pilipino kung hindi ang kapwa Pilipino din. So, ang alam ko, pinayagan limited number lang. Pero bukas naman ang pintuan ng IATF para makipag-ugnayan sa mga Philippine Nurses Association and other subgroupings, no, to continue with the dialogue or to look at what other options we have. But in the meantime, the number one objective is really to ensure there's adequate supply of nurses locally. But again, going back to what I said earlier, may mga personal reasons na kung bakit yung iba ayaw pumasok o binitawan na ang kanilang mga pwesto. So, yun na nga, tao-tao na lang na ang mga ospital, pakiusapan na lang yan na tuloy-tuloy. Again, appealing to their sense of nation, sense of people, sense of service. Ganun talaga. Hindi mo naman matanggal din yung takot. Pero ang kapalit naman nun, gumagawa tayo ng paraan na paunlad ang kanilang compensation, ang benefits. Ito na nga sa Bayanihan Act 2, meron nga tayo dito nga ipinasama na sapat na compensation and benefits, no, yung routine testing, life insurance, accommodation, transport, mental health services. So ito ay patuloy naman na pinuunlad natin kung ano man benepisyo ang kanilang natatanggap.
Okay, thank you very much, Sec Duque. Raymond, we've got some more questions.
So we'll just piggyback very, very quick comment or feedback po, Secretary, with regards to the comments received from the group of Doctors to the Barrio, sir.
Yeah. Well, yung sa Doctors to the Barrio, kung meron kasing emergency, may calamity sa isang lugar, halimbawa sa Cebu, no? Nagkaroon ng calamity sa Bohol, nagkaroon ng earthquake, kaagaran naman na kapagpadala tayo ng mga DTTB from Cebu to Bohol to respond to the calamitous event there. Pero syempre, iba yung COVID-19 . So naintindihan ko rin, syempre nung una nasaktan ako na bakit gano'n ang mga doktor natin na kung saan kinakailangan na meron talagang matinding problema na overwhelm yung health system ng Cebu, kailangan ng mga doktor naging pahirapan yung amin kagustuhan na rumisponde sila sa Cebu, pumunta sila sa Cebu. But of course, without necessarily leaving or abandoning their post. Kasi meron naman mga may mga next in line naman yan na nagpapaganap ng kanilang trabaho sa mga munisipyo, sa kanilang mga municipal health, city health, provincial health offices, no? At para makapagpatuloy naman ang serbisyo. Pero ito naman, temporary lang, sabi ko. Hindi naman as if lilipat mo ng matagalan, you can do it on a rotating basis. So, maigi naman at nung hindi pumayag yung mga DPPB at gaya ng nasabi ko, naintindihan ko din dahil yung takot, lahat, yung magulang, syempre na apektuhan din sila, ay hindi mo naman sila pwedeng sisihin din. Ano? But on the other hand, dapat siguro dahil as a state of public health emergency tayo, dapat basta nakakasiguro lang na ang gobyerno ibinibigay yung sapat na proteksyon, yung PPEs, yung kanilang accommodation, yung kanilang pag-asikaso ba sa kanila, yung mga pangunahing pangangailangan ay natutugunan. At yun, pero the system will improve, I should like to believe. And I would like to thank all of those doctors and nurses who came all the way from the different regions and responded to our call for their augmenting the very limited human resource for health of Cebu at that point in time. So, saludo po ako sa kanila. Marami rin po silang tumugon at wala po akong tigil sa kanila pong pasasalamat at pagkilala sa kanila pong pagmamalasakit at kanila pong pagbubuwis. Ika nga, sabihin na natin, syempre, binubuwis din nila yung buhay nila no? Sa mga ganito panawagan. So, I commend all of them.
Thank you, Secretary Duque. And for the next set of questions, may we call on Christian Esguerra from ABS-CBN.
Good afternoon po. First off, thank you very much for inviting me to this webinar. Magandang mapakinggan, for example, yung mga nangyayari sa iba't ibang hospitals. Now, basically, I have two major points that I would like to ask about directed to Secretary Duque. Hi, Sec Duque.
Hi, Christian. How are you?
Sir.
Yes, oo. Hirap ng trabaho eh.
Oo nga, sir. Sir, first question ko rito, correct me if I'm wrong, pero I remember back in May, the WHO's recommendation was that the positivity rate should be less than 5% for 2 weeks before governments should consider relaxing lockdowns. Pero ngayon, yung sa Philippines, diba, nasa 10.4% yung positivity rate natin. I'd like to know whether, how big a factor was this in the decision by the IATF to move from MECQ back to GCQ, and whether the recalibrated strategies during those 2 weeks would be enough to actually deal with the expected surge. Tapos number 2, Secretary, sorry not to put you on the spot. I've been meaning to ask you this. When you talk about the importance of basing every decision during the pandemic on science, I've been wondering if you've ever corrected President Duterte whenever he made those bogus statements about disinfecting masks. I know this might sound ridiculous to some, pero we know that on the ground, a lot of people might actually believe him, and perhaps this might even complicate efforts on the ground by health workers to explain things much better, imbis na hindi nila inaasikaso yung mga ganitong irritants. Yan, Secretary.
Well, the answer to your first question is the considerations supporting escalation or de-escalation of community quarantine is really on one, the case doubling time. Okay, if it is below 7, it means that you're high risk. If you are at 7 to 30 days, you're moderate risk. But if you are more than 30 days, then you're low risk. So in accordance with the risk classification, you will be assigned a category of whether you are ECQ, MECQ, GCQ, or MGCQ. Okay. The other metric that the data analytics uses is the critical care utilization rate. No? And the metrics for critical care utilization rate are, number one, the ward bed occupancy, the isolation bed occupancy, the ICU bed, as well as the mechanical ventilators, no, capacity. So these are two very important metrics observed by the data analytics in making their recommendation. And of course, adding to that are economic risks and security risks, and also the earlier on, even the mortality doubling time was also considered. So essentially, yan po yung mga metrics na ginamit. The positivity rate is something not definitive to me. It's a bit iffy if you use the positivity rate. Yes, ideally, dapat the more you test, di ba, sinasabi nila nung una, liliit yung iyong positivity rate. Pero we see that in many countries, the more you test, you actually are picking up more positive cases as you increase testing coverage. No? So that's not something that is absolute and therefore not a good parameter or indicator. So yun lang. Number two, yung sinasabi mo na yung mask disinfected, dinidisinfect using gas, yun ba yung sabi mo?
Yes, sir. Yung mga ganun statements, have you ever tried to, or actually corrected the president? Basically, subtle nudge.
Hindi naman kasi unang-una si Presidente can be playful. No? Sometimes meron siyang mga ganun off-the-cuff statements, but no means does he mean, it's nagbibiro siya, just, alam mo naman, parang hindi na tayo nasanay, 4 na taon na si Presidente dyan, ano? Na may mga ganun siyang mga komento, and he's not really serious about those comments. Nagpapatawa lang siya. So, yun lang masasabi ko. But deep inside him, he's really concerned with what's happening and that he really wants government to respond as best as it can and muster all the resources that there are. And his heart is in the right place, that kung siya lang talaga ang masusunod, yung health, primacy of health is for him the paramount consideration.
Thank you, Secretary Duque. Raymond, did we have one last question? Because
one last question
almost
po.
going into overtime.
Yes, thank you. I think we're in overtime na po, Dr. Susie. And thank you for that, for braving to answer those questions, Secretary Duque. I think this question po, and we are choosing the one that has been most upvoted by our attendees. The question here is directed to, I think, all 3 hospital directors po. The question here states, what measures are being taken whenever there is a surge of healthcare workers who test positive in a particular area or department of the hospital? And what specific methods of disinfecting the workplace have you seen that have worked best in your hospital? Maybe we can start with Director Gap and move on to Director Vince and Director Fritz. Director Gap.
I think that's the decision to close an area is one that's going to be very difficult. So we have employed a buffer system of nurses and staff, so that if one area lacks personnel because of testing positive, we transfer personnel from another ward to the other to those that are affected. Fortunately, we have a big hospital, and if we close off some areas, we'll have nurses available. So that's what we've been doing. We close off wards that we can compress patients into, so that we have available personnel as buffer. As far as the identification of those
disinfecting methods.
Yeah, or this. So we follow just the standard protocols that our infection control committee has suggested. So this is, of course, aeration is one. It's very important. Unfortunately, for those offices without windows, and there's some of them, we cannot do that. So we use the air purifiers or HEPA filters that are available to us. UV light is used also. This is after we make sure that we wipe surfaces with the common disinfectants that use as sodium hypochlorite.
Maybe we can hear from Lang Senator of the Philippines, Director Vince.
Yeah, whenever there's a health worker who becomes symptomatic, what we do is we test all the health workers within that area, no? And while waiting for the swab, then we quarantine the symptomatic health worker. While the rest who are asymptomatic, we presume that they are not infected because of the precautions that they're doing in terms of PPEs, no. So once the symptomatic becomes COVID positive, then we admit them. If the positive health worker is detected during routine swabbing or periodic swabbing, again, only the health worker who is positive is quarantined or admitted to the hospital. The rest, if negative, they continue without need for quarantine. We've been doing this, and we didn't have any problem about spread of the infection using this criteria.
Thank you, Director Vince. And go ahead, sir. Go ahead, sir.
It was only during the first part of the I think March or April, wherein we had to close an area, our isolation area, but that was the only time we've ever closed COVID ward or unit.
Okay, thank you, Director Vince. And last but not the least, let's hear from Jose Rodriguez Memorial Hospital, Director Fritz.
Good afternoon. For the institution, we have a weekly disinfection of all areas, no? Just like what Gapa said, we use HEPA filters, UV lights, and liquid disinfectants. And if one healthcare worker in one area is infected, just like what Dr. Balanang has said, all are tested for COVID-19. And if majority is infected, we get the replacement from the buffer group of the healthcare workers. And for those infected healthcare workers, if they are symptomatic, we admit them. For those with no symptoms and tested negative for the coronavirus, we let them go on duty to finish the 1 week duty on the COVID wards.
Okay, thank you very much, Dr. Fritz. I think we have a moment, Raymond, to just ask our guests to give us parting words, but I have a bit of a question. I'm going to start with Gap and have the question for everybody else. So, Gap, where do you draw your strength, and what is your advice to all the other hospital administrators who are listening to us right now?
I guess from the people themselves that you work with. The best inspiration to get strength from are exactly the people you work with. And of course, the patients that they serve also. So inherent to all of us as doctors, I think knowing how to deal with all kinds of challenges boils down to knowing how to deal with people also. So I get a lot of inspiration from the people I work with, and it also pays that occasionally you have times that you have your light moments, but in solitary thoughts, it's really the inspiration that comes from the residents, the consultants who go on duty, the nurses who keep their PPEs on to save on resources. So this is, I think, partly how most of us will be able to get through this also.
Thank you, Dr. Legaspi. Vince, where do you draw your strength? What's your advice to the other
Yeah,
hospital directors?
yeah, the same. It's still the people, no? They're really the one who keeps us keep me going every day. We meet almost every day. The people planning, trying to do corrective actions for safety incidences, coming up with a new idea. So actually, sabi namin, a lot of our young consultants here are becoming already stars, what we call, kasi sila yung very creative in trying to think of strategies to better serve our patients as well as help our health workers.
Thank you, Vince. Fritz.
Yes, ma'am.
Oh, where do you draw your strength, Fritz, as the COVID referral hospital?
Ma'am, from the start, we already had a saying here that we save as many Filipino lives as we can. For the strength, we get our strength from the employees of the institution. Pag nakita nila, ma'am, na meron kaming dinidischarge, yun ang nagbibigay ng strength sa kanila to move on. So, yun ho yung the best na way na we can get strength from the healthcare workers, seeing people discharged improve.
Thank you very much, Dr. Fritz. And I have to ask Secretary Duque that same question if he's still there. Sec, are you still around?
Yes, oo.
Oh,
Always.
Sec, put your video on. Oh, you're getting hit left and right.
Yeah.
You're working 27, 28, 29 hours a day. Where do you draw your strength?
Yeah.
Where do you draw your strength?
Ako, I draw it from my considering for the large part my work as a public servant, it being a vocation. Para akong pare, yun ang tingin ko rito eh. So that kahit na ano ang sinasabi, ano ang mga kritisismo, ang mga batikos, tuloy-tuloy lang kasi trabaho ito. And you know, public service is a special calling. No? It's not meant for everyone. Those who devote themselves to it find and experience, you know, fulfillment, no? Which are hardly found elsewhere. And the rewards are not material. No? They are mental, they are moral, and in fact, even spiritual. And these intangible rewards proceed from a sense of dedication to the service of the nation and to people, to the affairs of the state, to public good, and to public purpose. So, but you know, public service has its price, and public service is both its price and reward, in fact. So, dapat at a higher level ang consideration. That's where I draw my strength. It's a vocation. Thank you.
Thank you very much, Secretary Duque. I don't know if I'm the only one becoming emotional here, but anyway, we have to end. We have to end now, and we have our closing remarks by somebody who made it really possible to start this webinar series, to get everyone organized. Of course, there are many people behind the scenes, but UP Executive Vice President Ted Herbosa, you know, just made also continues to be as a force behind this learning experience for all of us. So may I call in Ted to say your closing, to give your closing remarks, and I think you've got the slide you want to share, but please
Yes,
open your video.
Open
and
your video.
yeah,
EVP
first before you
Ted.
show your slide,
Yeah, it's okay. It's okay. I'll
sige,
show
go
my
ahead.
slide.
Opo.
Is my
Okay.
video not open?
It's
No,
okay.
your video is now open, EVP
Yeah, it's
Ted. Perhaps
Go
you
ahead.
could also share, sir, your experience as special advisor to the National Task Force for COVID-19.
Wait, naggalaw yung slide lang. I want to show this slide. And I want
Okay.
people to look at this slide and read it as I do my synthesis. And I'd like to thank Susie and Raymond and Gigi and VP Nenny, and everybody that's Rika that's been doing great with this webinar. You know, I've been following this webinar since the beginning. This was an idea of Susie Mercado, and I didn't realize it was going to be this extensive with thousands of viewers and international even. So I'm very proud of the group and what it has done. But let me synthesize what I've been listening to for the past, what now, almost 3 hours now? I think we're on our third hour. And I think what the four people here are very humble. Secretary Duque, Director Gap, Director Famaran, and Director Vince Balanag. They're all very humble because they bring into the picture one important thing that is important in chaos. It's leadership. Leadership is what is most important in what Gap called, he called three things in it. He described science, solution, and solidarity. So the other big word I'd call in is solidarity. Now, I'd add one more S. And one more S, I think, is about systems, health systems. I've always wanted to become a hospital director. I wanted to be a PGH director. I ran for it twice. I never became the PGH director, but I became Undersecretary of Health and had a nice view of how the whole health system worked, what were the gaps, what were the problems and the issues. And I think it's very important that when you have a crisis as big as a pandemic like COVID-19, that with all the fear, all the chaos that was coming in, I think we should understand that it's all a systems approach, that we are all interconnected with each other. The epidemiologists, the molecular biologists, the politicians, the cabinet secretaries, the IATF, the military generals who ran most of the show, and all of us, even the doctors. What people didn't realize is that healthcare workers and doctors like Gap and the rest of our hospital directors are leaders themselves. And they can actually lead us and bring forth a lot of importance. And that to me is a very important thing. And this is my word of advice, having gone up to the totem pole of leadership, that for all the directors out there listening, directors of hospitals, directors of health units, and everything else, I think the important thing is to open your two ears, open your two eyes, talk less, close your mouth, and listen to everyone. And that this was embodied by the words of Gap. What empowers them are their people. Listen to your people, listen to what they need, give them what they need. There's a lot of disruption that happened. There's a lot of fear and anxiety that occurred. We had a lot of solutions that were gained here in terms and shown by Gap. A lot of things that were contributed, but I think I will put here the strategy that the government put out. This is the work of the IATF, led by Secretary Duque. And sad for me is that I have knowledge of this, yet many people in the healthcare sector have no knowledge of how the whole plan is. And they all keep asking for a plan on social media. Everybody's asking, where is the plan? Where is the plan? You know, I was ready to volunteer in PGH and help Gap out for this crisis. But Secretary Galvez called me out and asked me to help him in the National Task Force. And by that time, there was already a plan. This was in late March. The same time, Gap volunteered to be a COVID referral hospital. And this, ladies and gentlemen, I'll take time for this because there are over 1,000 people listening here. At least I'm going to get to 1,000 people in the health system who will know that there is a government plan. And the government plan is this trace, test, treat operational concept. And it involves a whole gamut of factors. When we're in the hospital, we tend to stay in the treatment arm. The treatment arm, which is really the clinical management, the running of the public and the private hospitals. But you've seen where Gap actually showed that they're actually also doing prevention, health promotion with those infographics, social distancing. They've also been doing testing. They've also come up with the idea that mass testing is not the right way to go, and really targeted testing is the proper way to go. Who else? One of the directors talked about contact tracing, being able to trace all the contacts of a person who gets infected, even in the hospital. So this is the same plan we have to do. The isolation facilities. As I visited all these hospitals with Secretary Carlito Galvez, I discovered there were unique bright points in everyone. Very clear to me is, for example, when I went to Jose N. Rodriguez, there was music. There was music every time someone was discharged. The nurses and the doctors told us, sir, that music tells us that there's someone is being discharged. And then there was another music that was scarier. It was like a da-da-da-dan. And then they said, sir, someone is being admitted. So anywhere you are in the facility, you can actually know what is happening at the admission area of that particular hospital. The other thing I noticed was in Lung Center, they had a lot of land. So they were able to build a facility for their healthcare workers to take care of them. Now we're building, with the help of the national government, we are building a 10-bed, 12-bed ICU there. It's going to be finished in a month. And these are our friends in the DPWH are able to deliver this. So, ladies and gentlemen, I think what is important in all of this, and I will synthesize this, is a systems approach to the problem. The systems approach is well highlighted by Henry Ford. Henry Ford, who developed the Ford motor vehicle. And he said, coming together is a beginning, keeping together is progress, working together is success. And with that, thank you very much to all our listeners. I do hope you have a great afternoon listening to our good leaders in the different COVID hospitals of the Philippines. Maraming salamat.
Thank you very much, Ted, for that very, what should I say, that very sharp insight into what's been happening and where we're going, and for pulling that all together for us. So next week, okay, so thank you to all our guests. Thank you to all of those who have attended, who are still on the webinar, and those who are watching us on the playback. We continue to answer your questions here, and we hope you have learned from it. Next week, we are going back to virtual grand rounds, and we will have a story of a newborn who was brought home, but the baby's lips turned blue on the second day at home. So be with us next Friday as we talk about that particular case in virtual grand round. So over to Raymond.
Thank you so much to all of our speakers, specifically Secretary Duque, Director Legaspi, the Philippine General Hospital, Director Vince Balan of the Lung Center of the Philippines, and Director Fritz Pamaran from the Jose N. Rodriguez Memorial Hospital. This webinar po will not be possible if I did not acknowledge all our attendees. So even if we are going 3 hours strong, we are still at standing room only in our Zoom webinar. At the CNN Philippines po, on the Facebook page, there are over 100,000 views of this town hall meeting alone. Wow. In YouTube, there are, I think over 400 or 600 viewers now on YouTube, or who have been viewing this on the live stream, and maybe madadagdagan pa po ito sa playback. And as mentioned, we reached nearly 1,800 registrants for this webinar, not just in the Philippines, but we have those from the United States, from the Kingdom of Saudi Arabia, and all those other countries na talagang masugid na nakasubaybay at talagang nanonood po, lalo na po for the insights that we gain from this national virtual town hall meeting. So maraming salamat po sa lahat po na nanonood. And next week, magsama-sama po ulit tayo for the 19th episode of our Season 2 for the virtual Grand Rounds. And have it's a holiday today. It's Ninoy Aquino Day. And have a restful long weekend po sa inyong lahat. So keep safe, keep healthy, and see you online.
The enemy remains unseen. I'll keep your hand in mine. Let's say a prayer one more time. I know you long for home, but I am here, you're not alone. I'll stay with you until the coast is clear. The others pain before my fears, the others laughs before my tears, but right behind the mask, I look into myself and ask, do I have strength to carry on? Oh God, how long must this go on? I need you here to keep me strong. I'm here to hold the line. I'll keep my word until my time. Just look into my eyes and say his name to realize it's fine to be afraid. Just hold on to the word he gave. This time will come to pass, 'cause this salvation's made to last. He'll carry you to see the break of day. The others pain before my fears, the others laughs before my tears. But right behind the mask, I look into myself and ask, do I have strength to carry on? But God, how long must this go on? I need you here to keep me strong. I'm here to hold the line. I'll keep my word until my time. The others bend before my fears, the others laughs before my tears. But right behind the mask, I look into myself and ask, do I have strength to carry on? But God, how long must this go on? I need you here to keep me strong. I'll keep my word, your word is mine. The others pain before my fears, pushing on despite the tears. Please take us through another day. Just hold my hand, and I will hold the line. I will hold